Nurse Jennifer Johnson, welcome to Lucid Commons.
Oh my God, hi.
Hi, I'm so happy you're here.
Thank you so much. It's been a while for us to kind of get here and I'm just so freaking pumped that we're finally doing it. We're doing the
We're
thing.
doing it. We're doing it. I'm very excited. Okay, can you tell us? Let's start off with who is Jenn Johnson?
So Jenn Johnson is an ER nurse by trade. She's worked for 18 years in emergency pretty well. Um, has petered off once or twice to do pediatrics and recovery room or PACU. But her undiagnosed ADHD leaves her always coming back to emerge. I am a wife and mother of two kids, 10 and 12, who are a joy, but my parents are absolutely laughing at retribution. um, and I am an author of the book Nursing Intuition: How to Trust Your Gut, Save Your Sanity, and Survive Your Career. And oh my gosh, and an entrepreneur running a study on new graduate nurses and how to retain them, or what they're feeling towards retention, with an international study that I'm funding, and not doing my master's or PhD or anything like that. Just kind of going, even if I work bedside, I should still be able to contribute to the overall knowledge that is nursing.
Absolutely. I love that perspective. I would love to start with ER nursing. So, for you, what led you to nursing and what led you to choose emergency room nursing?
So I fell face first into nursing. It was never on the radar. It was never a thing. My mom's a vet. My dad's a mechanical engineer. The college level, he's definitely not a PN, but he's, after 50 plus years, he's going to be pissed that I still don't know what he does 100%. So yeah, I was in biology and I was in my second year, and oh my God, failed the first half of a year long organic chemistry course. And it was the first time I'd failed anything. I'm going, I don't understand this in the slightest. I thought biology at Lakehead University was going to be people based, but they've got a massive forestry program. And so it was mainly plant based. I'm like, I killed the plants. This is not good. So failed that class. And thankfully, there was a girl that I lived in first year residence with, who was in nursing, and we'd like go through her Mosby's dictionaries and like, okay, this is cool, like this is what I want to actually learn. So thankfully was able to swap into a 3-year nursing program. And once I graduated, I had already met my now husband and we had started living together. And so moved into his hometown, which is a teeny tiny little northern rural town, to start working, because oh, we're gonna live together and it's gonna be so nice, and the whole genius dream of like, oh, let's play house kind of thing. And because the town was so small, the hospital only had like really two positions for RN. So on any given shift, there was one RN for emerge, one RN for the floor with two RNs or LVNs. And you just swapped back and forth every other shift. You just kind of go between the two. And emergency nursing had never really, I hadn't really thought about it much. But once I figured out that, oh, this really matches my personality and how I like to, in and out, and quick fixes and on to the next, on to the next, on to the next. I was like, okay, I think this is the fit.
So, what was that experience like working in a rural hospital compared to where you work now?
Oh, it's different. So we had no RT. We didn't even have a vent in the hospital, let alone in the town. Um, Limited X-rays, limited ultrasounds, limited blood work. They weren't doing lactates. That's how limited the blood work was, and I didn't realize at the time just how screwed you were if something actually hit the fan. Um, and so, you'd be sometimes you'd do a night shift, not one person would come into emerge. You're like, cool. The whole town kind of knew how the system works, so the family physician would cover emerge for the morning, and then they'd go to the walk-in clinic in the afternoon, unless heaven forbid something keep them at the hospital, and then they'd send all the people from the walk-in clinic to the hospital during a day shift. And you really didn't have any support whatsoever. And I'm actually quite thankful that it was my first job, because I think if I knew what emergency nursing could look like, I think I would have had a stroke working
Oh
rural.
my gosh. Okay, so you mentioned that you felt that it fit your personality. So, what is it about your personality that really jives with the ER?
Oh, the let's deal with big issues and not little teeny tiny nitpicky issues. You're not planning care 3, 4, 5 days in advance. It's a bandage and a treat 'em and yeet 'em kind of scenario where, you know, holy crap, you're not breathing. Let's fix that issue, and then off to hopefully an ICU bed. Off you go. Um, does it always happen that way? No. I mean, last night was actually a great night. I ended the shift with only two admit no beds or boarders. Um, so like, and that was the only two that we had in the department, which was actually great. Sometimes we sit at 6 to 8 to 14, and it is only an 18 bed department right now.
Wow. Can you talk for people who don't know borders or the context of an ER today?
Yep.
I know this is similar, right? ERs look the same in America that they do in Canada right now.
Yep.
So, can you talk a little bit about borders and what that looks like in an ER?
Yeah, so when we say border or admit no bed, it means you're sick enough to have been admitted to hospital, but unfortunately there's no bed up on the floor for you. So what you're doing is you're being held in emergency until there's that bed up on the floor, and we can do that transition. Canada is notorious for borders. That's just kind of the way our healthcare system works, as well as the aging population, the lack of nurses, yada yada yada. But I've had people wait as long as 180 hours, so like multiple days to be able to get up to the floor. So what that does for the ER is it blocks a bed. So that's one bed that I can't run, anywhere from 2 to 5 to 10 people in a shift out of, but it blocks that space. So unfortunately, then especially with your critical care beds, if all of your critical care beds are blocked, and all your medium level care beds are blocked, you're going, okay, well, there's 25 people to be seen. Where can we put them so that A, there's some nursing coverage for them, that the physician can physically see them? How do we get creative with space? So this is where hallway nursing comes into play. We'll put patients who, again, have been admitted into the hallways if it's appropriate. They're not isolated. They're able to kind of get up and mobilize themselves to the bathroom. They don't need catheter care management or something that's, really personally invasive, where you're in the middle of a hallway and you're trying to do care. If somebody is incontinent and they need their brief changed, like, that's not, putting them in the hallway is not a great move. So putting these people in the hallway, the lights don't go off until very late, and recently we've actually been having trouble with our overhead lights, and they're staying on. So that's a problem. You know, you're you're hearing everything that's going on in the department. You're not happy. You're trying to heal from whatever you've been admitted for, and we are giving you really awful circumstances in order to try and do it, so that we can free up a room, so that we can start moving people in and out, in and out, in and out. And then those people get admitted, and then we're like, okay, now we're down again. Now what do we do? Well, why don't we have some people who really aren't appropriate to be seen in kind of like our quick to be seen area, because we think that they're just going to come in, they're going to go out, kind of a walk-in clinic or urgent care feel, because the LVN or RPN is usually managing that side of it. If it's irresponsible to put a chest pain into that area, because what if they're actually a STEMI? What if they're actually having a heart attack, and you've paired them with an RPN that this is out of scope for them? And that's not fair to the RPN, let alone is it fair to the patient. but we know that we need to see these people in a relatively quick amount of time. So it's a game, and the more people you see, theoretically, the more people who are going to be admitted, and it's a constant balance, and then having to beg, borrow, and steal beds from upstairs to be like, hey, can we put people in your hallway so at least it's quieter, they actually have a chance at getting some privacy and healing a bit, and we need these beds. Like, we can't, the ER is at capacity, and when that happens they call gridlock, which means that all of your beds are filled, all of your critical care beds and your resuscitation beds are filled, so that if somebody were to come in and their heart stopped, you don't have a place to put that person, to be able to do CPR and do all the things and operate as a hospital, as well as having, I think, one or two ambulances on offload delay. So those ambulances can't offload their patients because they don't, again, have anywhere to go. So they then kind of start stacking up. And it's, you want to talk about chaos personified. On a day when you've got a ton of admit no beds or boarders, it's a hard go. And then, as an ER nurse, you're not used to trying to remember scheduled meds and, full assessments versus just very focused assessments. Repeating vitals again and again and again on a patient when we're typically used to doing one or two sets. And then, oh, yeah, now the patient's been discharged. Okay, bye, we'll see you later. And then kind of starting all over again. So it's hard to kind of get into the mindset of, an ICU nurse or a med surg nurse or a step down nurse when you're also then potentially, you might have half your people are boarders and half your people are ER level patients, and you've got to kind of manage the two mindsets.
Yeah, that's great that you brought that up, because I was going to ask you, just knowing yourself, knowing your personality, knowing what it is about the ER that you love, and then now finding yourself in this position where you are kind of like a step down nurse or an ICU nurse and having to flex between those different worlds, right? That's and it's the ER is chaotic already without, patients being in the hallways and without all these borders. So when I worked in the ER, I was a patient care technician. I never worked in the ER as a nurse. I was a PCT for a couple years before I transitioned to the medical ICU. And for me, I think it was a little too chaotic, right? Like, I have diagnosed ADHD. I know you were saying undiagnosed ADHD, but like, I have, and it's too chaotic in my brain to begin with. So I'm like, okay, I need organized chaos, not just pure chaos. And that's kind of how I feel, the ICU is. And you have that follow through, right? That was what I noticed too, is I really did. I wondered, what happened to these patients? Like, when we send them up there, to the surgical ICU, medical ICU, what happens? Do they get better? And I needed to know why, and that they were getting better, and again, have a little bit more of that organized chaos. But I did work with a lot of adrenaline junkies, right? Because when we think of ER and we think of the TV shows and we think of the pit, we think of ER docs who are adrenaline junkies, right? Have you had your fair share of experiences or working with people who truly are just like, they live for the thrill of, the STEMI or the incoming into resus, right? The trauma.
Yeah, I mean, and you have that moment, and you figure it out pretty quick because everybody's a little different when you pull up to emerge or you pull up to work, and there's like 4 to 5 ambulances lined up outside, and the correct response to that is like, oh my God, here we go. The ER level adrenaline junkie is like, oh, I wonder what's in there. Let's get going. Oh, and there's 2 cop cars. I didn't see that there were 2. Let's go. Like, just. It's a weird way to look at things, but every now and again you'd get that like medical mystery where somebody's coming in and their symptoms are super atypical of what they're complaining about, and you're like, what's going on? And you're kind of like figuring stuff out, and I mean, playing with your intuition and trying to be like, I thought that person was really, really sick. I wonder what happened at the end of the day. And same thing, like, yeah, sometimes you get no follow-up whatsoever. Sometimes our ER docs, if it's something that especially we all kind of felt, or we all got a sense that this one hit a little bit closer to home than your typical day, the docs are usually quite good at like, hey, by the way, I checked up on that patient that we transferred out to the cath lab, and this is what happened, and da 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 da. And so sometimes we do get the fill-ins, but it is very few and far between. We absolutely can't look. Once you're out of circle of care, you're out of circle of care. So that's kind of it. Um, but yeah, like that's probably the worst part of a merge is you run around like a maniac. You're starting IVs, you're doing CPR, you're getting a pulse back, da, 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 you're getting them all organized. You spend, an hour transferring them out to the next facility, and then you walk away. And you've got the whole, taxi ride home to go, what was that? What in the world just happened? Because I don't know if I even comprehending just what happened. And you really don't realize how much of it is like muscle memory, and just an automatic go until somebody new comes into emerge, like a new grad or somebody that's new to emerge, and you're kind of getting them in for a feel of what's going on, and then it hits the fan, and then you're like, okay, we're going, like let's get in the truck and we're going. They're like, what do you mean we're leaving the department? I'm like, oh yeah, we gotta go. Like we gotta go transfer this patient out. They're like, what? You leave the department? And you're like, why, yes, we do. Like, this is how we get patient from A to B, and to the level of care that they need. We've done what we've done for the moment, and things could change en route, so we kind of need to be prepared in case things change en route. But this is the gig, and sometimes it's wonderful. And last night, I don't know what happened last night, but we had a low census. We we got our naps on nights. It was, our nap breaks were fantastic. Um, so it was a really, really decent night. And again, when you don't have borders, you theoretically could close the shift out with no patients and emerge, which is also the game. That's the gold medal. But usually as soon as you have admit no beds or borders, you're like, oh,
Hmm.
no shutout tonight.
Hmm. I've never heard a nurse say nap break. I need you to say more about this nap break.
So, what you do on your breaks is up to you. There is an unwritten rule that has kind of been passed down. I don't know where it started or what's happened, and every facility and every floor is very different. So my first job, because there were only two RNs on the night shift, well, and the day shift, but day shift you actually had like a little bit of extended staff kind of kicking around. Um, so night shift, we didn't have, like, naps weren't part of the work culture. Like we didn't nap. There were some nurses who would kind of disappear for a period of time, and because nothing was going on, potentially, like, nobody really asked questions as to like where she went, and then she kind of showed up, and we're like, oh, okay. Didn't It took me a year or two to realize that she was going off to nap, in a back room. She just wasn't announcing it, and good on her for taking the initiative to put her health first. But they had bought us really nice recliner chairs for our nursing station, which was in the middle. Like, it went into an old patient room so that it was still on the floor. So what we do is we'd kind of like put our feet up. We had a big TV that we could roll in and watch movies on. And if you happen to pass out and nap, not too bad. Again, if anything were to come, um, the adrenaline hits you so fast that you're up in an instant anyways. But what you do on your break is your prerogative. Some people like to combine their breaks, so legally we get an hour and a half up here. So if you want to combine all of your breaks together and then have a solid hour and a half of doing whatever you want to do, sure. Again, the other unsaid thing is you're not technically allowed to leave kind of the unit. Maybe you can leave the floor, but in a pinch situation, you need to be, close by, so I can run in and be like, oh my God, we got a VSA on the way. You got to get in here. And, that person can get up in an instant. And we all understand the rules. You go down for your nap. The risk is that you could be woken up or have your break cut short. We get that. But on the other hand, if I'm staying on the unit, you can't tell me what I can and can't do on my break. It's just, there's a ton of studies on how sleep breaks improve cognition during night shift. You're trying to do what's best for your body, and obviously you're not taking breaks if the floor is on fire. And for the number of breaks that I've missed in my career, like now it's a priority because I'm not Superwoman. I can't do it all. My body, is used to night shift, but I'm also now 41 and things are changing. So it's like, do what's best for your body. If you can squeeze an hour and a half nap in, and have it be beneficial for you so that you can come back and be on your game, perfect. You do you.
Wow. That is an amazing piece of Canadian healthcare culture that I wish we could import into America because I've literally never heard of anything that you're talking about, right? Like I've heard of nurses taking care of themselves, right? But that's usually because, we work like 3 12s in a row and then that
Yeah.
fourth day at home, we're like a slug on the couch all day, rotting into the couch watching Netflix. And I don't think I understood that as a young nurse, right? I only practiced for 3 years and then, went to law school. So I didn't have the time to learn what you have learned, right? That you do have to put your health first because you cannot pour from an empty cup. And as nurses, we are healers, we are helpers, and we are quick to sacrifice our own needs, right? Let's talk about the nurse that doesn't pee for 12 hours and doesn't
Well,
realize that you've been holding your pee for 12 hours. You're like, "Oh my God, I gotta pee." I still do that to this day. I'm not even kidding. I will
oh,
just sit here all day and be like, "Oh God, I should
when
pee."
when I think back, and I mean, we used to, when I was a care aide, like in between nursing school semesters, you'd go around and you'd hear these care techs or the PSWs refer to people as heavy wetters, and they're like, oh, this one's a heavy wetter. Their bladder can hold a lot, so you need to make sure to check them more often, and if they can try and get up to the bathroom more often, like we really do need to be more on this because like they're a heavy wetter. And thinking back and looking at it, I'm like, I wonder how many of those people were nurses. Like, because it was these little old ladies that you had no, you didn't expect that this was, kind of an anomaly for them. And yet looking
Mhm.
back, I'm like, oh my God, am I going to be a heavy wetter? I'm like, yeah, 100%, because my bladder's already, not that it's shot, but like, can I mean, we have competitions sometimes. Like we used to have competitions at my first job is to be like, hey, how much is in your bladder? And so we'd sit there on a slow night and kind of bladder scan each other and kind of have these fun competitions for morale. And you're just like, oh, there's a full-on liter in there, and I still don't feel like I have to pee. Like, oh,
Wow.
okay.
Isn't
Yeah,
that the craziest thing ever?
it's nuts.
I Yeah, it is nuts. What I've been thinking about lately is, and I want to talk more about intuition, but what I've been reading up on lately is we're understanding it as the eighth sense, which is
Yeah,
interoception. Essentially, your ability to sense what is happening internally, like viscerally with your
yep.
organs. And it's that nurse's intuition, that gut feeling, and this kind of embodied intelligence and this embodied pattern recognition. And I just think it's funny that, as nurses who we have this intuition, but when it comes to sensing our ability to pee, we seem to just numb that, right? And just ignore it.
And you train, right? You're like, oh, I'm not a good nurse if I am going pee every 5 minutes. Like that, I can't do that. Like I've got too much to do. And you talk yourself out of it so often, where you're just like, no, 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 I'm good. Because like, of course, now this person's deciding to drop their blood pressure, and you're just like, oh my God, like I gotta deal with this. I don't have time to pee, and so you just keep holding it, and it's super unhealthy. I know that I will have chronic UTI issues as an older adult. I'm staring them straight in the face. Uh, uh, Bladder prolapse and uterine prolapse are going to be potentially more of a problem because I've had children and because of this. I know that these are coming down the pipes. It's just like, oh great, maybe 30 years from now, I can. These are coming down, and you're just like, that's, thank you, nursing. Thank you. Another gift that keeps on giving.
Gift that keeps on giving. Okay, so to any nurse that's listening to this,
Please
especially
go
the young
pee.
ones, please go pee.
Please go pee.
Make the time. Just
Yeah.
do it, right? Just do it.
Yeah.
Take care of your body. I wish I would have known that then to take better care of my body and not push myself so hard.
Yeah.
I want to talk more about nursing intuition. So you wrote a book on it. You
Yeah.
literally wrote the book.
Literally wrote the
Let's
book.
talk about it. Literally wrote the book. Okay, so how did you get there? How did we get there? Take us to a moment where you actually felt this intuition. Take us to the moment where you're like, oh my God, I got to write a book about this. I want to hear all of it.
Yeah. So the first time looking back that I knew that I was utilizing my gut, I was a brand new grad. I was coming onto the floor of this very small hospital. We actually had an acute care patient instead of some of the patients who had been there for months. He's the one, acute level patient where everybody's been there for months. So I go in, I do my vitals, and he's talking, and history of pancreatitis. That's what he's in for this time. Um, doesn't disclose that it's due to alcoholism, but I get that from report. And as I'm finishing up his vitals, he kind of doubles over and just like grabs his abdomen and is just like yelling out. I'm like, oh, like what is happening here? So repeat his vitals. They haven't changed. Obviously, the heart rate's come up a little bit and his rest rate's come up a little bit, but nothing's really changed. So I call the doc, and this is like 7:30 in the morning, just like, hey, this is what's happened. I'm not sure what to do. Like, what do you think? And they're like, oh, he's been in lots of times previously. Like, this is what he does, and his lipase has been higher than that before, and like I'll get there when I get there, kind of thing, and just kind of slipping me off. So I thought, okay, went back, did another set of vitals, still within normal range. So I'm like, okay, let me get you some Tylenol. No, not that that was great for the alcoholism in the liver, but got him some Tylenol and just like, okay, you do you. I'm gonna go see my few other patients. So see my patients, come back, repeat vitals, and they're starting to trend into what I now know is a sepsis picture. So heart rate starting to come up. He's starting to spike a fever within the next hour or so, even through the Tylenol, and blood pressure starts to tank and his rest rate's coming up. So through the hours for the next 2, 3 hours, I'm doing his vitals every half an hour, and I'm calling the doc every hour to be like, hey, this is what's happening. Like, what do you think? What can I do? Da, da, da. And, I get put off. I got, here, give him a 500 ml bolus and give him a little bit of morphine, and that'll help his pain and all this. And so like we were kind of treating it, but the doc was also really kind of nonchalant about what was going on. And so, we go through the day, it's 11 o'clock, 12 o'clock. Now we're moving this patient into our one cardiac room because now his blood pressure has dropped so low that we need to put him on medications to keep his blood pressure up. So now he's an ICU level patient because of these medications. He's starting, like his color's starting to go, like the fever's really starting to kick up. We're having to add a second pressor on, and his blood pressure just keeps falling. And it gets to the point where the doc finally comes in at like 12, 12:30, and we're like starting CPR because now his heart stopped because the blood pressure wasn't supporting it. And just kind of, worked him for half an hour, and the doc was like, yeah, no, we're gonna stop, and that's it. And so I remember walking to the back room, and again, this is like one of my first patients. What, and I'm just going like, what did I miss? What, like, could I have pushed harder? Could I have done something differently? Like, sometimes nursing school makes it feel like if somebody dies, it's on you. Like, that's your fault. If you were a better nurse, or if you knew more, or if you acted faster, you could have changed those things. When in reality, this man was sick chronically. Was it his time? No, maybe not. But I did all that I could do. And granted, it took a long time to get to that point of acceptance. Fast forward 5 years, I'm finally getting to leave this job, and we're coming back down south to Southern Ontario. And this physician, out of nowhere, kind of takes me aside, and she goes, oh, I heard you're leaving. I say, yep, I'm going. We'll see you later. I'm out. I'm done with this. And she goes, don't ever let anybody tell you you don't know what you're doing. And she just walked off. And I'm like, I know exactly what you were talking about. You've waited 5 years and me leaving to tell me this when I've been internally dying over it for the last 5 years. And you just confirmed to me in one instant that I was pushing. I did do what I needed to do, and that, you know, maybe you should have come sooner. You know, would it have
Mm-hmm.
changed anything? Maybe, maybe not. We theorized that he had perfed his bowel, and
Mm.
that's what had caused the sepsis to come on so quickly. And again, we're 2 hours away from any real medical help. Like, we don't, like, there's one ambulance for the town. Like, that's how small it is. So, you know, getting him out would have been, you know, unlikely, to be able to
Mm-hmm.
get to a surgical center. But yeah, so
Wow.
that was the first time that I was like, oh my God, like I did know what I was doing and I did call it
Yeah.
that something was off. And I just
Mm-hmm.
kind of got, oh, you're new. Oh, you're, you know, this is, he's done this before. Oh, whatever, whatever, whatever. And it took years to be able to
Wow.
look back on that and be like, oh, that was my gut. Like that was me
Mm-hmm.
saying, no, something's wrong. You need to trust me. And
Mm-hmm.
my worries were being put aside.
I can resonate with that so much, unfortunately. I'm sorry that it came 5 years so late for you, right? But that was some of the initial feedback that I had gotten. It was like literally at like my 3 month review. You know, you have great instincts. And it's funny because at the time, I didn't know much about nursing intuition. I thought maybe the nurses who had been a nurse for 40 years had nursing intuition, right?
Yeah.
And I remember almost being offended. I was like, excuse, okay, that's all you have to say to me. I have good instincts. Here's
Right.
me, new grad, I work in the ICU. I'm smart, right? That's so interesting. But it took me a while. Even hearing that though, I will say, I don't know that for you hearing maybe, but like that hearing it any earlier, for sure it would have been validating, but I don't know that I ever got to a point where I truly felt like I could trust my own gut. I would still second guess myself and, go check with, a trusted mentor or,
Yep.
someone who had been my preceptor and just, hey, like kind of, walk this through with me. Um, have you ever had a moment? I've had a couple of these, and unfortunately, where you were sorry that you didn't trust your intuition.
I think that first one, because
Mm-hmm.
I didn't quite have a handle on what was going on, like I just thought that that's what I was supposed to do. And again, 20 years ago, it was the still pretty heavily reliant on, oh, the doctor knows best, and you're subservient to the doctor, and you need to
Mm-hmm.
look for the you
Mm-hmm.
need to wait for the orders, like. And at the time, everybody else who was on the floor was like, "Why are you so worried? Like, what's going on?" Like, and
Mm-hmm.
I tried to tell them, and nobody validated me in that moment to be like, "Oh, yeah, no, like he kind of looks really sick," until it was way too late. And then they're going, "Oh, whoops."
Yeah.
Um,
Yeah.
yeah. And
That's,
yeah,
I think,
hearing it earlier, I don't know if that would have changed anything per se. Maybe it would have changed my some of my guilt, and I would have leaned
mm-hmm.
into it sooner,
Mm-hmm.
um, versus feeling like, oh, that's on me because I missed it, or I
Yeah.
didn't push hard enough.
Yeah. Yeah. I would say I see nursing intuition and then the agency and empowerment to act on it, is two different things. You need both,
Oh
right?
yeah, oh yeah,
So I think that is where I've had moments where you trust your intuition. You know that something is wrong, right? Something is not right here. I think what was so challenging, I'm sure for you as a new grad and me is like finding your voice to say, "Hey,
yeah,
I think something is wrong." One thing that helped me is realizing, oh, if I am just this new, baby nurse in the ICU running back to the resident saying, "Oh, I think something's wrong. Something just feels off, right? I don't know what it is. I know."
yeah.
That did not, I did that a couple times and that did not go over well, right? So I'm like, okay,
No,
what can I do to make them listen to me? And I would go get the data, right? I would say,
yeah,
okay, like how can I discipline my intuition? I would go get information. I was, okay, well, what did their progress notes say from yesterday, right? What were their labs this morning? What did their chest x-ray look like this morning? What do they look like right now? Like, what's some assessment data that I can give them? Like, where is that gut feeling? Where's that pattern recognition coming from? And that got me a lot farther, than just, oh, I think something's wrong here, right? Because doctors, like you said, there's this kind of hierarchical, subservient relationship. Unfortunately,
Mm-hmm.
sometimes doctors will not give your voice that much weight or credibility or respect sometimes, which is very unfortunate. But I will say the doctors, I say the good doctors, right? The ones, especially the residents, some of the
Yeah.
residents know that nurses know more than they know. And so
Yeah.
they will come
We've
to
been doing
you.
it. We've been doing
Yeah.
it. We've seen this
Yeah.
happen. We've seen this go down. We're trying again. And so when I talk about it and people are always like, well, how do you get it across? Because yeah, trusting your gut and knowing that something's wrong is half of it. The other half is saying something. And
Hmm.
it's a little bit easier to merge when your docs are there all the time. You get to know them quite
Hmm.
well. We don't have the data points necessarily to be like, oh, here's this whole long pattern, and last time this happened, this is what happened, blah blah blah. Um, so talking to your doc, if you say, you know, I think my patient's deteriorating, here are all the reasons, and I'm just advocating for my patient. Do you know what stops a doc super fast? That word. That word will stop people in their tracks because they go, whoa, that is a buzzword. That is the word to catch your attention. And me telling you, this is a big deal. And it will be in the charting that I was advocating for my patient because nothing sounds better read out in court. Like, oh, nurse notified MD at at this time, at this time, at this time, at this time. Patient, RN states advocating for patient. No orders received. Any nurse who reads MD notified, no new orders received, knows exactly what that is. That is 100% cover your behind moment where I know something's wrong. I know that there's been a change. I've tried to tell the physician blew me off. But I have done this. And the more times you see that in a chart, I can guarantee you that patient's going to crash out. And it's not just with one nurse, it'll continue with the next nurse because sometimes these processes take time and, will take days. And those of us who can kind of, same thing, do the pattern recognition, have experiences to pull kind of information on to be like, oh, the last time this happened, it was like a pneumo. And all of a sudden things just went sideways so quickly. So let me just preemptively kind of, hey, like, their breathing's kind of off and the sats are kind of off and I've had to go up on the O2 and they're complaining about a little bit of pain. Like, I don't know. Like, can I get an x-ray? I've already paged RT. They're already here. They're kind of under the same impression. So now that's two of us going, no, something's got to happen. Um, and you're right. The good docs will stop and they'll listen because it only takes getting burned by one of these scenarios where you put off the nurse and then all of a sudden patient dies and it's a coroner's case or it's part of an M&M where a morbidity and mortality meeting where the docs will go through a patient case scenario and talk about what happened and what was done and what wasn't done and could we have prevented this catastrophic outcome, or was this inevitable due to patient history or disease prognosis or whatever else? So it's interesting that I'll use the word advocating because like even so again, I've written the book on nursing intuition. Do you think that I'm going up to my physicians to be like, my intuition is telling me like that Mrs. Smith is not going to do well? Like we're starting to circle the drain a little bit. Absolutely not. It's an ongoing joke actually with my workmates because they'll just be like, I'll say something, they're like, did your intuition tell you that? I'm like, shut it. Like, yes, it did, by the way.
Mhm.
And guess
Mhm.
who's right a lot of the time? Not all of the time. You will never be right all of the time. But
Mhm.
I would much rather use my voice, say something, have nothing be wrong and have nothing be changed, and the patient be covered than to not say anything, potentially have a catastrophic outcome, and then be carrying that ghost with me for the rest of my career.
Mhm. That one word, advocate. I love that.
Yep.
That's advocate plus CYA, right? So advocate
Absolutely.
plus,
Absolutely.
because that's what they teach you in school, right? Is if it's not
Yes.
documented, it wasn't done. So document that you
100%.
advocated, right?
Yep.
I I want to know what actually inspired the book. So what was the moment that you were like, "Oh my God, this I need to write a book on this."
So working COVID, frontline in the ER. My kids were 4 and 5 at the time. Daycare closed. My parents are about an hour away, but they got super freaked out with COVID. They kind of went down the rabbit hole. So they said because both my husband's infection control, like, haha, along the way, because we were both frontline workers, and we still continued to go into the hospital. My parents kind of said, you know what, we're gonna take a step back. We think that you'll be okay. My mother-in-law, who had always said that, oh, I'll be there for you always. And it took a lot to call her to be like, hey, can you come down? Because like we're losing it. Like we can't handle this. And oh no, you guys are okay. So, kind of left to our own devices. And so I was working all night and then staying up all day with the kids because they're 4 and 5, and you really can't leave them to their own devices. And then I'd be up all night, and then I'm up all day, and then, 2 and 3 shifts at a time. And I was quite literally going out of my mind. The lack of sleep mixed with the depression, mixed with the anxiety, mixed with, you know, questioning if life is going to go on, like what the heck's happening, all came crashing down. And so after a few weeks, I was like, I'm hitting a wall. Like I don't know what else to do. And we had a lovely group of lawyers come forward and be like, you know what, we just want to make sure that everybody's covered. We're going to do everybody's wills for free, which, looking back, is the nicest thing anybody could ever offer, just to make sure that everybody's kids are taken care of, like everything's legally in order. Like, how lovely. Um, at the time, felt like, oh, we're all gonna die. This is what's gonna happen. We're not expected to make it out of this. Oh, okay, which really tipped me over the edge. That I was already like carefully, sauntering on anyways. And so I'm like, okay, well, how do I explain to my kids if I passed that, mom chose to continue to go into work. So I was like, let me write down my good stories, and like my good stories about nursing. I had a couple of those, and oh, okay, it's been 15 years at this point. We'll write these down. And because there was nothing left, I was like, all of the trauma just came all the way out. And so, anything that I hadn't dealt with, which was everything, um, came flooding out. So, all these stories. So, the story about my first patient there, my first pediatric death, a bunch of other stories along the way. And it just like blurted out of me. And I'm like, okay, what do I do with this now? Like this, I don't know if I want my kids to have these stories. Like this is a lot to be dumping on a kid someday. And was listening to a podcast, and they're having online book fairs. And so Llewellyn, who's a metaphysical publisher out in the middle of the state somewhere, was like having these book fairs. I was like, okay, something that's kind of very not what I'm hearing every day. I need to just listen to something else. And the one that I caught was this woman talking about her book, Intuition at Work. And what she was referring to was like intuition in business, intuition in the legal sense, in an office setting, not in healthcare. So I was like, intuition at work. I'm like, I use my intuition all the time at work. And it was just this like light bulb moment where I'm like, oh my God, that's it. And so sure enough, went back through all my stories. Every single one had some element of I trusted my gut. I said something, I didn't say something. I was somebody, somebody believed me, they didn't believe me, and I was just like, okay, like that's where this is all going. So I kind of put it all together, and I said, I think I actually would be risking my license if I put this concept out there. And it's not like it's a concept that I'm coming up with. We talk about this all the time at 3 a.m. But to put this out into the real world and be very open and vocal with it, I think I better look to see if there's any like science behind it. Because I'm like, I need just, excuse me, a little bit of science. And I'm like, looking, and oh, maybe there's one or two papers within the last 5 years. There were 800 papers within the last 5 years on specifically intuition in nursing. And I'm like, oh my God, okay, yeah, this is it. And, school teaches us that no matter what you believe, if it's backed by science, that's where you go. And I'm like, this just worked out just perfectly because this is my own personal experience and now it's validated by science. I'm like, okay, if somebody's going to be the one to talk about it, let it be me, and let's go.
Wow. Okay, so 800
800
studies.
papers. I was
Wow.
like shocked. Absolutely
Okay.
shocked.
Wow. How long did it take you to write this book? Right. So it's a collection of lived experience, so
Yep.
stories
Stories.
and science.
Yep. And
Tell us about the process of writing a book. Like you wrote a book. Like that is no
yeah,
small feat.
no. And to be 1,000% honest, I don't remember writing it. I don't know if it was because I was so sleep deprived. I mean, I remember getting up
Did you
really, really.
dissociate? I feel like you maybe
Oh, 100%.
dissociated from the
100% I dissociated. 100,
Oh
like I'm
my God.
getting goosebumps because
Wow.
100% I dissociated.
Wow.
Because of, the lack of sleep and all this going on, and I didn't know what was going on. So, and this is August of 2020. So, especially in the Canadian version of things, we were still in the middle of it. Like we were still, things had barely opened up. We were still super restricted at the hospital. We were still wearing masks everywhere and all day. Um, so I write all these stories, and I'm like, getting up super, super early to write. Like, I'm talking like 3, 4 in the morning to like get a story out. And oh yeah, what about that? And then I'm staying up really, really late, which again is not helping anything, looking back. But I'm just like, it just all came together so seamlessly that I'm like, something, you can believe in whatever higher power you want to in any which version. But it really did feel like this is something that is supposed to happen right now. And I don't have the energy to fight it. So let's just go with it. Why not? People already think I'm kooky and weird anyway. So like, who cares?
Lean in.
Like,
Lean in.
let's go. Because again, like once you really come face to face with your potential, well, your own mortality, you come real up close to it, and you're watching all this death around you, and you're out of your mind because you're sleep deprived, and the kids are adorable but needy, because they're 4 and 5, and your parents have kind of, who have always been there for you, have kind of stepped away, and that was a whole other blow the ego that you're like, whatever at this point, like who cares? I mean, you get so glib with it that you're just like, bring it on. If you think that I don't know that I'm already insane, meh, welcome to the Jen show. The ongoing
Welcome
joke
to the
is
club.
also that like if I ever need a new therapist, you want to know how I'm going to save money? I'm going to give them a copy of the book to be like, hey, I know that you and I are new. But this is like volume 1 of why I am the way I am. Like this is the work edition.
Hmm.
Here you
Hmm.
go. We're gonna
Hmm.
save a lot of time and understanding. Yes, this is in
Hmm.
my point of view, and yes, that's got problems associated with it. But this is my story. Here you
And just
go.
skip, a couple years worth of
We're just gonna skip at
sessions. Yep.
least five thousand
Skip
dollars
forward.
worth of therapy right
Yeah.
here. We're gonna
Oh
skip it.
my gosh. I love this conversation because I love just being so open and candid about trauma and therapy and the experience of what it is actually like to be a healthcare provider, to be a physician, to be a clinician, to be a nurse, and the experience that we all had throughout COVID. I mean, whether you were a healthcare provider or not, if you lived through COVID, you
Yep.
experienced trauma of some sort. So that's like the entire globe, right?
Yeah.
And
And
we just kind of carried
collective
on.
trauma.
Collective
We
trauma, but then we carried
collective
on.
trauma. Well, and so I teach with Nurse Blake now. Like I've gone and taught at camp one time. I'm teaching at camp this year, and I'm actually teaching on the cruise next year. And when we were talking about, okay, let's, what are we going to do this year that's a little bit different from last year? Because I taught nursing intuition and how to grieve your patient last year. I said I'd like to redo the how to grieve your patient one because that actually that had everybody bawling, myself included. Like actually, I'm pretty sure like in all four of my classes, I'm like, I don't know how I'm here, guys. Like, if you think that I'm some whiz, I'm not. Like, I'm just, you're questioning why I'm here. I'm questioning why I'm here. We're all questioning. But in talking about how, what to teach next year at camp, and it's more of a holistic, how to care for yourself as a nurse, I said, you know what? Let's do a 2 hour COVID debrief because nobody has debriefed COVID. We've all just continued on. Depending where you lived in the world, you had a very different experience as to the length of restrictions and the severity of restrictions and the length of time, isolated and separated by other people, and everybody had a different variation of, how close to death they were exposed or how much death they were exposed to. And we just continued to like putter on. Like nobody questioned that, hey, can we stop for just a half a second to really take in what the heck has gone on around here? Because this is insane. And we need to debrief. Like nobody's done that. So I thought, you know what? I'm no trauma counselor. However, again, we've all had our own lived experiences, and I've got a lot of tips and tricks. God bless my own therapist who's gifted me with these tips and tricks. And so why not, you know, actively trigger people for a very short amount of time, because it does not take much. Even to this day, it does not take much that I could just kind of lose it, which shows you just how bad it was. I there was a distillery in town that had gone from making, I think, gin to hand sanitizer during COVID. And they were one of the very first people to do it. They were very quick to donate these free bottles of hand sanitizer because we were running out of hand sanitizer at the time. And like they stepped up. And I was driving home from work the one day, and I saw their sign. I'm like, I need to stop in there and tell whoever's running the place that like that really made a difference. All of a sudden, I am bawling because that sends me right back to where I was, and the chaos and the fear that that time period carried. And I'm like, whoa, why am I crying over potentially just visiting a distillery that has gone back to gin? But okay, that's
Mhm.
another lovely little thing another little COVID nugget that I didn't know was sitting in there, but here we are.
Yeah, it's that's one thing that I'm learning about. So I haven't, and it's funny because I thought I was working on it at the time, because I was in therapy throughout COVID, and I thought, I would talk about patients that I lost and, really, really devastating situations, but I didn't realize until long after COVID, long after I left the bedside, that there was unprocessed trauma because I'm reading. Have you read The Body Keeps the Score?
Yep,
Okay,
love
so
that
it's
book.
it's it's
Love
so
that
good.
book.
I'm very early in. I'm only on like chapter 6 right now, but that is one thing that, and I'm so mad that my therapist didn't tell me this, because here's the thing, you can't outthink trauma. You can't
Yep.
out-talk trauma. You can't just talk about it for an hour with a therapist once a week and expect it to go away. And that is what I was so mad. Why didn't you tell me that trauma lives in your body? It's that
Yeah.
almost that pattern recognition. It's stored in your nervous system, literally in your cells. And you have to take a bottom up approach to get it out, to repattern, right? And I that's just this feeling that I'm having right now is a like, okay, why didn't you tell me? Right? What do I pay you for? But also just kind of having this realization that like, wow, there's so much that is unprocessed and it's bringing a wave of grief. Like you
Hmm.
said, in teaching this workshop, this how to grieve your patient, I'm not surprised at all that nurses, it just kind of turns into this collective sob fest where it's coming out of you and you can't control it, right? I'm so curious about what does that entail? Like how are you walking nurses through grieving their own patient, especially when it's so deferred and delayed?
Yeah. But we carry it like it's right here. You can, again, any, sometimes there's specific smells or triggers or words or a memory or something that reminds you of that scenario that, you go, oh man, and you're in it before you even realize that you've kind of gone into it. And, you know, so that was my first pediatric death. Like she was here all the time. And so if another kid came in that reminded me of her, my own daughter, and again, the reason I think it hit extra close to home because it was always going to hit extra close because it's a kid and I was my first. But my daughter was the exact same age as this was happening. And I was already have supposed to have been out of the building as this, call came in for this poor little kid. So 3 in the morning, I'm going home and I'm waking my daughter up, who's 2, and I'm waking her up and I'm like, hey, I'm throwing all of the blankets out of the crib. I'm waking her up. I'm like, okay, you're awake, yep, okay, like you're alive, okay, and like I sat there, God, for must have been an hour, and just the silent mom tears as you're holding your kid, and your kid's falling back asleep because they're an infant, right? Like they're like, oh, what are you doing? Um but it's just like you have those moments where you're like, oh man, this one's gonna live close to home. And it wasn't until I found a therapist who, and again, didn't go for work therapy, went for, hey, me and my husband are having a little bit of a spat. I'm looking for some support for marriage counseling, or at least for me. And that was my first kind of exposure to therapy. And she, I spend three appointments, complaining bitterly about my husband and our scenario and what's going on, and I'm right, and then so the fourth appointment comes up. She's like, so we've talked a lot about you and your husband. I'm like, I'm sorry. Yes, we have. And she goes, I just, for an intake. I'm like, oh my God, I haven't done the therapy process right. We haven't done the intake. Like, oh my God, I feel so bad because I've messed up therapy already. And she's like, no, you haven't messed anything up. It's just, let's do, now that you've got the bulk of what's simmering at the top off, let's kind of go into it and say, just a little bit about your history and what's gone on and any points that I need to be aware of or any triggers that I need to be aware of. I'm like, oh yeah, perfect. So we're going through the intake form and she's like, so any trauma that you've experienced in your life? And I'm like, especially as a female, I'm like, no, I've been exceedingly lucky, thank God, that I've come out of, childhood, teenagehood, and early adulthood unscathed. And then I'm like, well, work. She goes, oh, and so we got talking about this little girl, and she went through an exercise where, you tell her everything that you want to tell her, and you wrap her up in a sweet little blanket, and you kind of like let her go up in a hot air balloon, and like you need to let that go. Like you did what you could at the time. This had nothing to do with you as a person. This had nothing to do with you as a mother. This was just a scenario that you just happened to be a part of. And unfortunately, it was a negative one. So, I'm the therapist is I'm giving you the okay to let this go. Like, you don't need to hold on to this as closely as you have been, um, because, your suffering, that's not indicative of how you felt or how much it affected you. Like, you don't need to keep it so close. Like, you can actually let that go a little bit, and that's okay. Like, you're not expected as a nurse to like hold it and feel it daily kind of thing. Like, that's a lot. So she was fantastic in that, and it was the same kind of visualization that I did with the class was, I, at the very beginning, I said, you know what, think of that patient. When I say you need to grieve a patient or a family member, there's somebody who's going to immediately pop into your head. And I need you just to remember who pops into your head first. It's not to say that they're the most important or they made the most impact. It's just that's what your body is telling you you need to deal with right now, and this is the opportunity. So, did my little spiel about all the different kinds of grief and what we can do and this, that, and the other, and then went through this visualization. And it's the same thing, you're wrapping that person up. They're happy, they're comfortable, they're smiling, they're alive um, as they were meant to be alive. They're thanking you for everything that you did. They've got all of their most favorite things with them in this basket, and you go around and you undo one corner point at a time and then the hot air balloon kind of lifts up slowly, and and you can feel the anxiety and the stress and that bubble of emotion. You feel it come up as you visualize like letting go one string after another. And, it's kind of like, I know this is uncomfortable and I know that you want to back out. And if you absolutely need to back out, please do. But I need you just to push through just that little bit more and be comfortable with the uncomfortable, because you shouldn't be comfortable with this. This is obviously, you've hung on to this for whatever reason. So we really need to deal with it. So, if you just hear me out, just give me 2 more minutes and we'll work through this. And so, you're letting the strings go, and this person in the basket's telling you thank you so much, and this is what they need, and I'm gonna start going now. And so you let them go, and they go off and they're waving and they're so excited and they're safe and they're happy, and you need to let that memory go. It doesn't mean that you let it go fully. It just means that you let the immediate pain of that kind of come away from you just a little bit, so that you can continue to do your job and be a mom and be the spouse and be the friend and all these other, you can continue to do what you're being asked to do every single day and not have that kind of weigh on you as heavily. It's not to say that you're going to forget what's going on or forget that person or that memory, but you don't need to be carrying it as close as you have been.
Yeah,
Oh no, I got you
I'm,
going.
I'm, I'm taking it in myself because I mean, even as, of course, as you were talking, you think of that patient, you think of the one.
Yep.
So,
And it wasn't your
yeah,
fault.
I'm so happy that we're having this conversation because I think so many nurses out there, and I was actually having a recent guest on my podcast was my undergrad philosophy professor, who is also a medical ethicist. And she was talking about the language that we use to describe clinicians during COVID. We started importing
Ugh.
war and battle metaphors to physicians and nurses. And she was just talking about how it's so peculiar that we were putting the onus on clinicians to defeat death, in some circumstances, to defeat the inevitable. And then we as nurses, you're right, we internalize that as, well, there's something more I could have done. Obviously I could have done more. Obviously it's my fault. So I really appreciate you walking us through that exercise. And it's helped you. It's helping the nurses that you're leading this workshop for. And I think more nurses and just more people, everybody needs to hear about this process for letting go of grief and not letting it continue to control you and like live in your body the way that it does. It's so heavy to carry.
It's too
Wow.
much. And after almost 2 decades, I'm like, you better believe I've got my certain subsect of patients who still live with me. I mean, I've got one from nursing school even that, she's still here, she's still kicking around. Like she wasn't as close as, that kid ended up being. Like that kid ended up being like, you watch your own daughter now grow up and you're like, you can't help but make comparisons. So it's, and then on top of it, what, there was a Facebook post. So her obit showed up on my Facebook feed, which I'm like, I did not need to see her alive. Like that just made things 1,000 times worse. Um, and then there was a Facebook moms post in one of our local groups, and it was the friend of the mother who had just lost the kid, and oh, you've just, there was somebody who just complained about this person at McDonald's, and they just totally lost it on. Don't they know that she just lost her kid? I'm like, now I know where she works. I'm like, oh man. I'm like, I can't with this. I'm like, oh no. I'm like, I don't need this.
Oh, wow. Okay, so in thinking about, because you're still a practicing ER nurse, you're still
Yep.
experiencing loss and grief and now that you know how to care for your body and how to fill your own cup before you go filling anyone else's cup and caring for other people, what does that look like? Because I don't think this is just applicable to nurses. I think this is applicable to anybody. How do you care for yourself and for your body and for your mind before you care for others?
It's an ongoing struggle, to be fair. Nurses are the absolute worst at taking care of themselves because, again, there's been this stereotype that at least I was kind of, it was ingrained in me that you're not a good nurse unless you give all of yourself. If you leave anything for yourself, oh, you're so selfish. And what do you mean you took time off to collect your mental thoughts after your marriage almost broke up? Like, what are you doing? Couldn't you just show up? Why aren't you showing up sick to work? Like, come on, like push through. We used to push through all the time. So there's a lot of that stereotypical kind of, why can't you push through and grin and bear it? Being that's clashing now with the very open and honest, we are struggling conversations. Um, and it seems very generational. It definitely seems like different programs lean on it more than others. My program very kind of covertly put this in. It definitely was in at clinicals, which of course the school couldn't really know what was going on in clinicals. But you heard that from the old nurses that you were working with at clinicals, and you kind of got instilled that well, you don't need, who sleeps? Nobody sleeps. If you're working night shift, you stay up with the kids afterwards. Like you don't. Why aren't you're sending your kids off to daycare so that you can sleep? Huh. Unreal, ridiculous. This generation is so soft. Please, please, unbelievable. So, I
Mhm.
mean, the fact that especially the newer generations coming into nursing are so quick to be like, I'm going to protect my work-life balance. I'm going to protect my mental health. I'm going to step away if need be. Um, at the rate of 30 to 60% of new graduate nurses leave nursing entirely within the first 2 years, which is insane. Um, like it's just there's so much more in tune, and yet when I talk about nursing retention and what we can do to change it and how we can support people better, I'm usually met with, oh, this generation's so soft. Oh, well, we did it. Like, do you understand what nursing is like today? Like, this is not the nursing that we saw 50 years ago, not even 20 years ago. The violence has escalated. The role of a nurse has escalated. Depending on where you're working, more and more is put onto you because, there's budgetary constraints. So we're going to cut out housekeeping, and we're going to cut out ECG techs, and we're going to cut out lab techs so that the nurse, you can't cut out the nurse. So, but guess who then gets to take all the rest of it? The nurse is going to pick up all the pieces and make it all go. Oh yeah, and by the way, we're going to give you an extra patient and a hallway patient. Um, it's fine, it's cool. Like of course these new grads are going, this is insane. What are you guys doing? And
That
walking away. Like, to be fair, for as much as we get angry at them, or when somebody actually sets a boundary and the nurses get angry because they're like, what do you mean they're not going to take another two more patients? Like, I'm taking 13 patients. Like, why are they stopping at six? I don't understand. And I'm like, okay, but listen to what you've just said. Why are we taking 13 patients? That's insane.
right.
That should not be happening. And do we realize that, we're trying to wade through the really heavy bit, especially in emerge, it kind of comes in waves, simmering down by early morning hours. So you're kind of slogging through it in the late evening to try and push through and get everybody seen, and make sure that everybody's kind of, you know, taken care of, and to try and tee things up as best you can so that the doctor, it's a one touch and off they go. But, here's this new grad who's setting her boundaries, and she's in a role that is a newer role, that where how many people she takes is up to her or him. And she's deciding, no, I'm going to stop at six, and that's enough. And, for people to kind of like go in on her, I'm like, are you really mad at her, or are you really mad that we've been conditioned to accept 13 and look down at those who are stopping at six? Because I feel like this is not where the anger should be landing.
Mhm. It's unfortunate, and I know you and we talked about nurse bullying, right? And the,
Oh,
nurses eat their young
yeah.
culture a little bit, which is very unfortunate. But I think Gen Z, even younger millennials, I think we were very much taking the brunt of that, because you're right, we're showing up to this broken healthcare system saying like, what is this? Like, what actually is
What's
this?
going on?
What is going on?
The
And
curtain's lifted now that you've got the job there, and all of a sudden you're going, what?
yes, yes. And the more senior nurses who have been nurses for, decades are like, well, what do you mean? I feel like underneath there's almost this assumption or notion that, oh, well, I survived this, so you have to too,
and
right?
and it's another form of bullying, right? Oh, I'm gonna drop you off into the deep end. You're gonna sink or you're gonna swim.
Mm-hmm.
That's enough. That needs
Baptism
to
by fire. Mm-hmm.
baptism by fire for sure. And so
Mm-hmm.
when I see it happening on the floor, I'm like, whoa, 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 what's happening here? What are you doing? Oh, well, we're gonna see if she can sink or swim. I'm like, no, we're not. We're not doing that anymore. Like, come on. Mind you, this woman is
Yeah.
also like about to retire, and has got the nickname of Scary Mary. So it's like, that's enough. We don't need to be doing
Yeah.
that.
Mm-hmm.
This is not
Mm-hmm.
how things should be done, or ever should have been done. You guys are all nuts.
Yeah.
And
Yeah.
we've acclimatized to the nuts. And so now we're also kind of nuts. And, because we've been in it so long, everything's very easy. It's muscle memory, everything's second nature at this point. It is not second nature to the new grad coming in. And, not only have they had to learn a new language, um, you know, increase their exposure to violence, and learn all these medications, and have the weight of life or death hanging on them, and so they're struggling to come to terms with it. Well, no kidding.
Right. Right. What do you expect? Do you
What do
expect
you
anything different?
think?
Right, right. And I saw this, I don't know if you saw this Becker's article the other day. So they found that the top three skills that new grad nurses are deficient in are critical thinking, communication, and practice ready skills, right? Like just being able to insert an IV.
Well, 100%, because they
And
don't teach that in nursing school.
well, right, exactly. And I understand that like to a degree, you can only get good at critical thinking, right? When you're actually in practice. You can only get good at communicating with patients when you've been communicating with them for a long time.
Yes.
So there is a degree of like, okay, we need maybe more simulation or more patient interaction, or maybe require that nurses in nursing school actually go be a nurse's aide or a PCT, right? Um,
100%.
to get that
100%.
experience. But how are nurses supposed to build those skills when they are in a psychologically unsafe environment or being bullied by their peers, we are just, as nurses in general, we are in fight or flight for 12 hours. We are just trying to get through the day,
Easily.
do what we can for our patients. And then, like you said, ride home in our car, like trying to process, like, what even was that? And it's almost like because of the nature of this system that we've built, we can't do the healing. We can't do the work that we're supposed to be doing to our full
We're
capacity.
exhausted. And then the trauma just keeps happening. There is no reprieve, like
Hmm.
there's no, if you go again, you do your 2 days, 2 nights, 5 off. That first night, everyone's like, oh, you get 5 days off, or you get 5 days off. That first day is a sleep day. That is a sleep day. That is not a day off. And to the nurses who I've heard, oh yeah, I'm going to stay up after shift, and like, you've just done a set of 4. You're coming off your second night shift. You're going to go home and stay up until you go to bed at 9 or 10 at night. Are you insane? I'm like, I mean, if that's what works for you, kudos. I cannot work like that. I, again, sleep with COVID and everything that went on with COVID. Um, Sleep has become my number one do not mess with non-negotiable.
Hmm.
So having a nap pre-night shift, and I play a little bit of nap roulette where, I'll try to go down at 12 o'clock or 1, and don't set an alarm unless it's for like 5:30 when I absolutely have to get up and get out of the house within a half an hour to be on time to work. But I play nap roulette, and I'm just like, you know what? I'm going to let my body decide how much it needs.
Hmm.
Because
Your
let's
body
be
will
real,
tell
so
you. It
the
will
body will
answer.
tell you. If I could theoretically pass out for 12 hours, clearly that's what I needed, because, you're not sleeping just to sleep. Like, that's not what your body's doing. Your body's going like, oh, thank God, we've got a moment for rest and repair. And, the nursing bladder's not going to let you down now. Now it's actually going to work for you. But like, you know, I've been there where you've come off shift and it was just such chaos, and you know that you're off for a good amount of time in the next couple of days. I have been out for 12 to 14 hours before, pre-kids, but exhausted, mentally, physically, spiritually, emotionally, completely left with nothing.
Mhm. I'm glad you mentioned spiritually, just mentally, emotionally. So I saw this TED talk recently on the 7 types of rest. Have you seen
Ooh,
this? There's,
I have
yeah, there's,
not.
I don't have them memorized. I should pull them up
That's
if I'm
okay.
going to
I
be
can Google it.
mentioning them right now. So there's this TED talk on the 7 types of rest that just talks about why you keep waking up every day, still exhausted, drained mentally, emotionally, spiritually. Well, Americans just in general, if you look at the statistics, we do not get enough sleep. Right.
Yeah.
And very, very poor quality at that if we are sleeping. And I don't think we put enough emphasis on the fact that sleep is really a healing process for your body and your brain, right? The lymphatic system
Yep.
literally cleans your body, right, when you're sleeping. But in addition to actual sleep at night, you need social rest. You need
Yeah.
emotional rest. You need spiritual rest, intellectual and cognitive rest. There's all these different types of rest that we need from different stimuli that are just part of our lives, right? Aside from just getting our, 7 to 9 hours of sleep at night. And that I think is important for nurses, especially because we are so mentally, emotionally, we're taxed in every, spiritually, physically, we are taxed in every way possible when we are working. And
Yeah.
I want to hang with spiritual for a second. If you're willing to share, what what does that look like? What is spiritual exhaustion? What is spiritual rest for you?
So spiritual exhaustion is definitely when you have those like really complex ethical, moral things that pop up at work that bother you to your core, because again, we all lie differently on on the ethical and moral dilemmas. Um, and so when somebody's coming in, and again into the emergency department, grandma was already palliative. Grandma was at home. Everybody was on board with this plan. She's actively dying. Unfortunately, circumstances change. She goes into active dying process, which is very scary if you are not used to it. It's very like audibly loud and then again, once you come to the realization that, oh my God, this is happening, the fight or flight kicks in and people's emotions kick in and all this buried trauma potentially from their childhood comes up, and people in an instant can't cope. So they do what, seems like the only option to them, which is call 911 and bring them in. And so, they bring grandma in, and sure enough, we're kind of end stage. We're really trying to transition. Um, and all of a sudden there will be one or two family members who go, "Oh my God, do everything." And when people at the last minute while somebody's dying change their mind and say do everything, which means you're doing CPR, you're doing intubation, you're starting the blood pressure medications to bring up their blood pressure, like you're going above and beyond and going into heroic measures to save this person who is actively dying of natural causes. So for me personally, it gets very, very hard because this happens more and more because we're, especially the Canadian side, we're very much pushing dying at home, but unfortunately we're slow to catch up to, we need to prep the family and have them have enough supports to be able to cope at home, because all of a sudden we're asking these family members to be the nurses and change mom's diaper and turn her and give her sub-Q medications for pain and stress and anxiety and all this kind of stuff. And we've given them like a quick overview of like, hey, these are the meds you could give, and like the nurse has got 16, 17, 18, 20 other people to see, so they gotta go. And we're pushing people into this spot where the inevitable is on the precipice, and they freak, and it's a completely understandable thing. But then when they come into hospital, that narrative changes from let mom go and let mom die in peace to, oh my God, we have to save mom. I don't want to be the one to say don't do everything, like do everything. And it's just a natural flip for people unless they work in healthcare or work somewhere where death is very common for them, and there's not this taboo to it. So you get caught in these ethical nightmares where grandma sent a DNR, grandma's wishes are well known to everybody, the POA suddenly changes their mind. And unfortunately, especially in the world of legalities, the physician and the nurses are all looking at each other going like, you've got to be kidding us, right? Like, she's actively dying right now. She's got moments, if not a few hours, and all of a sudden you want me to break all of her ribs. You want me to shove a tube down her throat. You want me to give her pain medications that stop everything. And I know that you deal with this in the ICU. It's just horrific to watch because, like, what, in your own head, you're going, like, this is absolutely insane. I wouldn't do this to my worst enemy. Don't they understand that this is death? Sometimes isn't the enemy. Sometimes death is like, it's a natural process. It's going to happen to every single one of us, despite what we all tried not to believe right now. But like, it's going to happen, and at the end of the day, if it's going to happen, there's nothing I can do to stop it.
Yeah, I think the ethical dilemmas and the moral distress that nurses feel, we don't, that's not part of the training. That's not part of the conversation as much as it should be, but it is a huge part of what we live with every day. And it doesn't, I mean, it doesn't, I experienced a lot of these big cases that you're talking about, right? Especially in the ICU, these really difficult situations. But it's even the smaller little daily things, right? Like the micro instances that kind of build up into a realization that, oh, I'm a cog in this really broken system, just trying to do my best with the resources and the information I have for this patient. And you find yourself, I found myself at points just feeling like helpless. And I'm just curious, like, if you experienced My theory, and as nurses, we do our best in the healthcare environment. We do the best that we can for our patients, but I do feel like to a degree, maybe as a system, as a collective group of healers and clinicians, we have this degree of learned helplessness where we just acknowledge that we are in this system. We're going to try to do our best. Not
Yep.
great, not even good. We're just going to try to do our best and keep the patient alive, do what we can for them, smile, make eye contact, right? Like,
Yep.
and that's it. And
Yeah.
I remember doing some research and I found so our regulating body in the United States, so the Joint Commission, I found that when they do a root cause analysis on a sentinel event, they find that 80% of them come down to a communication failure or a cognitive error.
Yeah.
And I'm like, why aren't we talking about that? Why aren't we training clinicians? Why aren't we architecting systems where, it's been what, decades since To Err is Human came out? Have we just accepted that To Err is human and okay, we're not going to try to be better?
Yeah.
You know?
I don't know. I don't
I
know.
don't know either. It's tough right now. And the way I want listeners to know too, like the way that you were describing what's going on in your Canadian ER is very much what is happening in American ERs right now. This is not just a Canada problem. This
No.
is an American healthcare system problem also.
To be fair,
Um,
it's a global problem. So the
yeah,
NHS in the UK, they're having the same issues. It's the generations are living longer, um, are older. Like we're just starting to see the end of the baby boomer hump. We've got all these clinicians leaving. It's just a recipe for disaster, and unfortunately, we're just smack dab in the middle of it.
yeah, all we can continue to do is to do our best. And I mean, you're still practicing showing up at your ER every day. So thank you for being out there doing that. I wanted to ask you about one lucid moment that you had talked about is you encountered early in your career a peer, a
Mm.
nurse who you decided that you would be nothing like, and that became a huge part of who you are today. Can you share that?
Yeah. So in my first job, we had somebody who's kind of like not really a nursing manager. We couldn't quite figure out what she did, but she was only there Monday to Friday, 7 to 3. She kind of helped with the telemedicine appointments and did the scheduling and did whatever she wanted to do. Like she'd been grandfathered into this position, um, and she was awful. She made it her life's mission to make many nurses' lives hell, mine included. You know, have never come close to, you know, suicidality or those kind of thoughts prior to nursing with her. But I definitely had those thoughts during. And it got to the point where when I finally got to quit, it was just like, you know, I'm going to be the most educated nurse to ever leave this place. And when I finally got the opportunity, it was just so liberating, um, because it's like, you know what, you know, for all the awful that she did, had she not been so awful and so mean and did all these things to me, I wouldn't have been so motivated to leave. And the little town is dying. It's currently in the middle of wildfires right now. Um, it has not gotten better. It's only gotten worse. And I'm just to take a step back and go, the silver lining of this horrific experience was I got to get out. And not only did I get to get out, I got to leave on my terms and will refuse to have anybody treated the way that I was treated. And it's really long term spiraled into this whole kind of support for new grads and trusting your intuition and all these kind of facets that I've kind of got going on. Um, had she not been that awful, I don't know where I would be right now.
That's beautiful that you can turn something that, caused you so much suffering in the moment. And I'm sorry that you got that it was that bad. I've never heard of nurse bullying being that bad where
Oh my
another nurse was driven to suicidality or suicidal ideation. So I'm so sorry that that happened to you. I can't even I mean, I've had bullying, but not bullying that's that bad. So for you to go to the depths of your soul and decide that you're going to transform that into who you are today and being supportive of new grad nurses and trying to increase retention and helping nurses trust their intuition, all these different facets are really cool. And even as we've been like, I'm having a lucid moment like myself throughout this conversation because when you reached out on LinkedIn, like when we got connected, I don't know, I've just been wondering through all the conversations that we've had, I'm like, okay, is it the universe, right? Is something, what's at play here? Because I feel like you and I were supposed to meet. Or it could just be like a really good algorithm, right? Maybe our LinkedIn algorithms are just so dialed
They're so
in.
on point.
I'm just so happy that we met because this conversation has been such a gift, and I know it's going to be a gift to other nurses and really just anyone who listens to this conversation. So thank you again.
Thank
Don't know if it was
you.
the universe or if it was our super dialed in algorithms, but I'm
Whatever,
happy it happened.
whatever. Same.
I'm happy it
Absolute
happened.
same.
Yes. I do want to ask you, so my closing question for every guest is, I don't know if you've ever seen Wicked the musical, but there is this song in there called For Good, and this song gives me chills and like brings me to tears every time. It's such a beautiful song. And I would love for you to think of For Good and the line in there, because I knew you, I have been changed for good. And think of someone in your life that you have crossed paths with who has said something or done something for you that taught you something about yourself, about the world, that made you see yourself differently, see the world differently, that changed you for good. And if you could finish the line with, because I knew you, what would you say to that person?
So it was going to be that previous story, but then something else just popped up into my head. So of course I always roll with it. So to the nursing school teacher who in passing one time said, trust your gut. And that's all she said. And then she went on to the next topic and all this kind of stuff. Thank God she said that, because I don't know if I would have put as much stock into nursing intuition had a university professor not kind of opened the door a little bit to start with.
That's beautiful. Thank you for sharing that moment with us. Jenn Johnson, this has been an incredible conversation. So thank you. Thank you for your time. Thank you for the gift of this
Oh,
conversation. Until next time.
see you.